two areas of technology which have been developed and advanced recently have assisted us in being able to better apply minimal intervention dentistry approaches. The first is around preventive products that have been developed recently or have been modified or enhanced recently to be more effective. So these products have built on our increased understanding of the way that the disease process occurs, so both related to the bacteria and the way those bacteria operate and metabolize carbohydrates to produce organic acids, which then are problematic in dental caries, but also our understanding of the way the dissolution of the hard tooth tissue occurs as well. That understanding has meant that we're better able to develop products to interfere with those two processes. So things like fluoride, we've known about fluoride for some time in terms of its remineralizing or its prevention of demineralization, but we've only recently started to discover that fluoride in itself interferes with the mechanisms of acid production, for example, of the bacteria, and other chemicals such as xylitol or chlorhexidine, for example, also interact with the process to prevent disease from developing. So these products are available to us professionally, so we can apply these products therapeutically to our patients' teeth, concentrated fluorides, for example. And also these products have been incorporated into things that people can use at home. Specifically toothpaste is probably the most important one in relation to dental caries prevention. But also some other products such as mouth rinses and sprays, lozenges, chewing gum, those sorts of things. So these preventive products help us to use minimal intervention approaches to managing dental caries. The second important area is around adhesive material development. In the past, I've talked about amalgam being our only sort of restorative material available to us, and because of that, we had to sacrifice sound areas of tooth surface or tooth structure in order to build a mechanical lock for that material. Now that we have new and improved restorative materials, they mean that we can actually remove much less of the tooth structure when we're eliminating cavitations. And the two types of materials that are particularly useful are glass ionomer cements and resin composites. And those materials are adhesive and also to a certain extent are biomimetic, so they can replace tooth tissue in a more effective way than amalgam was able to. So considering the cycle of restoration, the area where we could intervene to prevent a person entering the cycle of re-restoration is in the area of making a good diagnosis or good diagnoses. To be helpful to us, a diagnosis must be two things. It must be able to be carried out in a timely fashion. We've talked about the terminal end of dental caries as being cavitation or even tooth loss. At that point, making a diagnosis is too late. So we have to think about the way diagnoses can be done earlier and in what we would call a more timely fashion, so that we're able to more effectively manage the disease therapeutically. The other thing is the diagnosis must be accurate. So we must be able to actually say that there is disease present or there is not disease present. If we're unable to do those things, then that will lead to idiosyncratic decision making. So we have a number of false positives, so we will actually say that there is disease present when in fact there's not. The risk of that is that we will intervene surgically when perhaps we didn't need to. On the other side of the coin is the situation in which we say that there is no disease present, so there is health, when in fact there is disease present. So those false negative diagnoses are also problematic because it means that we can't instigate early therapeutic management of the disease. Or, in a worst case scenario, if a disease is very serious, then not knowing that it's there could be detrimental to the patient. So diagnoses have to be timely, so be able to applied early in the process, and also they have to be accurate so that we make the right decisions about care for the tooth or for the patient. But we also need to think about future risk. So what is the likelihood, even if we have a person before us at the moment who is healthy, what is the likelihood that they may develop dental caries in the future? So this is where we use our risk assessment. So we think about the risk of future disease for patients. The other thing is keeping in mind that dental caries is a dynamic process and that the lesions can go through periods of activity or non-activity or rest. We need to actually be able to determine that. So a diagnosis that tells us, yes, there is a lesion present, so we're able to detect it, but also that tell us whether the lesion is progressing or whether it is arrested or whether it is reversing, is also a useful piece of information that if we can get that into a diagnostic test, we should build that in. Dental caries risk assessment is an area of ongoing development. In terms of developing a good risk assessment test, we've found that there have been significant problems. The predictive power of risk assessments is one of the methodological problems that we're currently trying to overcome. So the thing with tests for anything, diagnosis or future risk of disease, are imperfect. There is no one test that is absolutely accurate and 100% predictive or 100% certain in terms of diagnoses. So what we need to do is to look at the balance of destabilizing or protective factors. Remember our seesaw or our balance in our patients' mouths and in their life, to determine whether or not they are likely to be at risk. There is not one single factor that can be used to predict future dental caries occurring, except past dental caries. So the best predictor we have of whether someone will get dental caries in the future, which will lead to cavitation, is whether or not they've had cavitation in the past. Unfortunately, that's not a terribly good test because it means that the indicator we're using to determine future risk is current disease, and by that point it's too late. So we need a more sensitive measure, and one of the ways to overcome the imprecision of any one of these factors in predicting dental caries is to consider them all. So when we work with patients or individuals or families or even groups within the population, we need to determine the relative contribution of each of these factors that you see on the screen. So we look very carefully at diet and the plaque in their mouth. We can measure things like the amount of plaque. We can measure the acidity of plaque. We can measure the amount of particular bacteria in plaque, for example. We can also look at their salivary flow. So there are tests that we can do at the chairside, which are relatively simple and low cost, to actually determine how much saliva a person is producing in a resting and in a stimulated state. We can also look carefully at the buffering capacity. So there are very simple tests that have been developed that look at the buffering systems, the 3 buffering systems within saliva, to determine the quality of the saliva. We can also look at things like fluoride exposure, for example. So that would require a knowledge of the fluoride in the environment that a person lives in, so knowing which areas are supplied with fluoridated water, but also asking our patients to report to us any products that they may use that contain fluorides. We can look at all of these factors together and then start to look at the seesaw or the balance and actually make some early judgments about whether a person is at greater or lesser risk because of what we see with this picture in terms of destabilizing and protective factors. So a careful gathering of information from our patient, both biological or clinical indicators, and also the data or the information that they report to us through our conversations and question asking during our examination or initial patient encounters. When looking at dental caries activity, we need to remember that everybody has subclinical caries activity in their mouth. Whenever they put fermentable carbohydrates into the mouth, the oral bacteria will produce acids, which will then lead to some degree of demineralization. Fortunately for most of us, our mouths are in ecological balance, and so over a short period of time the pH returns to neutral or normal, and the minerals are redeposited on the tooth surface, meaning that we don't have any progression towards cavitation. So when I talk about caries activity, that's not really what I'm suggesting we should be able to detect in our patients. I'm talking more so about very early clinical indications of disease progression. So for example, if we see white spot lesions, for example, on the enamel surface, that is the first clinical evidence that we have a disease process that is progressing towards cavitation. So minerals are being lost, more minerals are being lost than are being redeposited on the tooth surface. So the white spot lesion tells us that there is currently active lesions in a patient's mouth. So how do we see or detect these active lesions? Well, traditionally what we've used in dentistry and oral health is a mirror and a dental probe. And most commonly in the past it's been that sharp sickle probe. But for very good reasons, the use of a sharp probe is not useful, nor is it indicated any longer for detection of caries or cavitations, which was what it was used for in the past. We continue to use the mirror and sometimes a blunt or ball-ended probe to give us a sense of what a lesion feels like, but we no longer use a sharp probe to push down into fissures or areas of tooth to see whether it sticks. This sort of behaviour will actually lead to us breaking down the surface of enamel in early lesions and actually creating a cavity. So what we should be doing is, what our job really is about preventing cavitation from occurring, not from assisting cavitation to occur. So be very cautious with the use of the probe. The other tool that's been used widely in clinical dentistry and oral health is radiographs. So we will expose a tooth to X-rays and collect information on a film, which helps us to determine the level of demineralization or tooth structural loss in particular areas. And this is really useful still in clinical dentistry. So radiographs and taking good radiographs will be one of the skills we will need to assist us in determining whether lesions are active and progressing. However, there are some new technologies which are emerging, or sort of new. Some of them aren't quite so new, but the new thing about them is they're being used more so now than perhaps they were in the past. And one of those tools is dental magnification. One of the commonly used devices for magnification in clinical dentistry are loupes. So the loupes that you wear assist you to actually look more effectively and closely at the tooth surface. So dental magnification should be something that is used routinely in clinical dentistry to allow us to detect early lesions, but also, if we are restoring teeth, to ensure that our judgments about which parts of the tooth structure need to be removed by us are actually much more accurate if we use magnification. There are some relatively newer technologies such as laser fluorescence and quantitative light induced fluorescence. And these devices have been talked about in the dental advertising world, but also in the scientific literature. And there is some current application or usefulness of this technology, but in terms of day-to-day assistance in a clinical setting, it is currently limited. Here are some pictures of these types of diagnostic tools, or let me be very clear, they assist us in making diagnosis. They are not definitive by themselves as tools for making diagnoses of dental caries. The laser fluorescence device, which you can see on the top left-hand side of the screen, is a commercial product called Diagnodent that is made by Cavo. This was quite fashionable at one stage a few years ago, but has lost its sort of appeal. The laser fluorescence device is useful for particular purposes, but is not, as I say, a tool which will definitively indicate whether or not there is a cavity in a tooth. It is a tool that we can use to assist us in our decision-making process. One of the problems with this laser fluorescence Diagnodent tool is that it is very easy to misuse this particular tool in a clinical application, and that misuse leads to a very high level of false positive readings. So there's a real danger with this particular technology of deducing that there is cavitation present when in fact there is not. So this tool, if it's used by itself to determine cavitation, is leading to a lot of over-treatment of teeth that don't really need treatment. So it needs to be used very cautiously. On the right-hand side of the screen is the quantitative light-induced fluorescence device, and there's some interesting work going on at the moment with this particular technology. This technology is useful because it actually is able to quantify, using the fluorescent indices of enamel, it's able to quantify mineral loss from a tooth surface. So it's very useful in smooth surface lesions to actually determine whether or not those lesions are losing more minerals or gaining minerals over time. But again, it is not a device that can by itself definitively say that a tooth has cavitated or not. So watch this space with this technology. It may become more sophisticated, and one of the problems with it currently is it's very, very expensive. So again, its application in clinical practice is limited because of that. But as technology advances over time, the costs of these things may be reduced, and so quantitative light-induced fluorescence may be something that becomes more mainstream in clinical practice in the future. There are some things that we can actually do to test whether or not someone is at risk of dental caries prior to seeing the first clinical signs. When we talk about risk assessment, we indicated that, or I indicated, and I indicated that there are some things that we can ask questions of the patient, and we can also record some clinical observations from a patient that assist us in determining whether or not someone is at risk of dental caries, or help us to make a judgment about whether the lesions we're seeing in their mouth are currently active or not. So we can analyse their diet, we can look at the frequency and the constituents of a person's diet. We can also do a test of the buffering capacity. So there are some commercially available products, and you can see one of them here on the slide, a commercially available product made by GC, which actually measures the capacity of the three major buffering systems in a person's saliva. And if there are deficiencies in that buffering capacity, the test will identify that. We can also measure the pH very easily of saliva, so we can determine whether or not someone in their resting saliva state has a higher or lower pH level. We can also look at the thickness or viscosity of saliva and how much of it a person is able to produce to tell us whether they have adequate flows, or potentially whether there is something wrong with their saliva production. And we can also look at the bacterial levels in a person's mouth, doing some tests on particular species of bacteria. This last area of investigation is a little more difficult to do in a clinical situation, because it usually involves taking swabs or saliva and having a commercial professional laboratory determine the bacterial profile of the plaque or the saliva test. So oral bacterial levels are relatively more difficult to conduct in a clinical setting, but the other points on this screen can all be done chairside using very low technology and low cost products. We also have some software to assist us in making risk assessments for our patients. So the helpful thing about these particular software is that they allow us to enter information about a particular person. So we can look at their diet, we can look at their plaque control, we can look at their saliva, we can look at the buffering capacity, we can look at the pH, and we can put all this information into the fields in a program like Cariogram, and the program calculates, using sophisticated algorithms, the degree of risk that a person has for developing new dental caries in the future. And these software can actually show us in a pictorial form, which is easily understandable for us and for our patients, the relative contribution that each of the risk factors make to their total risk profile. So it can show us whether their most significant risk factor is diet, for example, or for another person, diet may not be the most significant risk factor, but their bacterial load in their mouth, for example, might be. Or it could be that their saliva is compromised, and therefore that is the most significant contributor to their overall caries risk. The beauty of being able to do that is that you can focus your intervention or your therapy or your treatment on the most important components of that person's dental caries risk, rather than treating all patients as the same and giving them the same advice and the same treatment. We can actually target those components of their total risk profile that are the most important, and that's really much smarter and potentially much more effective. So an important part of controlling disease, the first phase of our minimal intervention dentistry, or the first dot point in minimal intervention dentistry, controlling disease really is dependent on us collecting information about the patient and their disease profile. So we need to know what does their disease currently look like, and we also need to know what are the risk and protective factors that this person has around them or within their mouth that is influencing the progress or not of disease. And then we can focus, if they are progressing in terms of their disease, we can focus our interventions towards particular areas. The control of disease is very important. It's the first stage in managing dental caries using the minimal intervention dentistry approach or philosophy. It is not a good idea to launch directly into definitive restoration of cavities until the disease is controlled or under control. So what we need to do prior to definitive restoration is to ensure that we use all of the tools we have available to us to try to arrest the disease process in a person's mouth. So those things include making sure that their saliva is sufficiently in sufficient volume, so there's enough of it, and also of good quality. Chewing gum is a simple strategy that we can suggest to patients if they have low levels of resting saliva. So for example, if they're dehydrated, stimulation of salivary flow by chewing is one strategy we can use for people with those problems. So a simple sugar-free chewing gum, if it contains xylitol or some of the other chemicals that we know are useful as well, is very good. It stimulates saliva and it could also contribute to reduction in bacterial activity through the addition of those chemicals. For people with extreme saliva flow problems, so people who, for example, have poorly functioning saliva glands, for example, as a result of radiotherapy to the head or neck, there are saliva replacement products that can be used that are commercially available that will lubricate the mouth and provide some protection. We can also think about chemical control of bacteria. So chlorhexidine is extremely effective as a short-term measure to eliminate or reduce chlorhexidine is not specific in terms of the bugs it targets. It's a wide spectrum antibacterial chemical, but it's very, very useful for the short-term control of bacteria that causes dental caries, and also also helpfully reduces periodontopathogens as well. Xylitol is another chemical that we spoke about, which is actually useful because it actually interferes with the production of the extracellular polysaccharides, dextrins and levans, which help bacteria to adhere to one another and also to the tooth surface. So that chemical, if it's introduced to the mouth, can actually be useful in terms of eliminating those mutant streptococci in particular, or reducing their numbers. If you do have cavitations in the mouth which are acting as reservoirs for large amounts of bacteria, so if they're open holes which are filled with biofilm, they're actually pools which will supply, pools of bacteria basically in the mouth, which will assist in keeping the bacterial levels quite high. So if you're thinking your chemicals and a patient's mechanical plaque control at home, so brushing, etc., is not sufficiently controlling the plaque, and that these cavities are acting as areas of or reservoirs of bacteria, you can elect to temporize the tooth. So place a temporary restoration. A GIC is an excellent material to do this, to actually isolate the lesions from the mouth. So placing temporary restorations into cavitations with the careful explanation to a patient that these are not definitive restorations, but they are merely temporizing the tooth to eliminate bacterial accumulation in their mouth and reduce the overall load of overall count of bacteria in the mouth. That is a useful strategy as well. So this careful control of disease by reducing the bacterial loads in the mouth, by remineralizing the tooth surface that has become weakened, and by reducing the ability of the bacteria to produce organic acids. All of these are components of the first stage of management of dental caries, the control of disease phase.